السلام عليكم. بسم الله الرحمن الرحيم، وعلى بركة الله نفتتح الجلسة الرابعة لمؤتمر جمعية ارتفاع ضغط الدم. المتحدث الأول هو الدكتور رياض محي، Consultant Nephrology, University of Karbala College of Medicine. His lecture about hypertension and chronic kidney disease.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you, Mr. Chairman. Thank you, ladies and gentlemen, to give me this appointment. And I have to give my gratitude to the organizer who gave me this yellow flowers that make my tension down, and I don't have no more hypertension. And I will talk to about the nephrology perspectives as far as the hypertension. The learning objectives, I will talk about the hypertension across different aspects of the chronic kidney disease, started from conservative treated CKD to CKD dialysis, whether by hemo or peritoneal dialysis, and CKD transplantation. And I will recall the guidelines related to the blood pressure targets and the impact of the drug-based management, and I will give also further algorithms about the approaching to people with hypertension and different phenotypes of the CKD. It's not working. No. So I think it will. At the end of this presentation, I will give 5 pearls that can be take-home message. As my colleague just described, that the hypertension in CKD patients, its prevalence is from 35 up to 85%, and this is depend on which stage of the CKD. So if you talk about 1/3 of people who got hypertension with the CKD, this is mean that the people of grade 3, 2, and 1. While in advanced grades, grade 4 and 5, the prevalence of hypertension is approaching more than 3/4. KDIGO 21 and the NICE and the European Society of Hypertension and Cardiology, there are some difference in between them and the definition and in the management. The KDIGO advised control of blood pressure less than 120, especially when there is albuminuria, while there are some debates between the others guidelines. In NICE and European, they put the cutoff value of 130 of 80 millimeter, and especially when the proteinuria is reaching to a level of A3. And the European Society always put in consideration that don't aggressively treat hypertension in certain population, which are include the elderly people and those who are diabetic. This is our study that is published in the Journal of Karbala College of Medicine in 2017. We collect patients who have non-diabetic glomerular disease as a primary glomerular disease. And we found that overall the prevalence of hypertension in non-diabetic glomerular disease is approaching around 2/3 of the patients, which is equivalent to the current studies of the KDIGO dependent. The most common glomerular disease associated with hypertension in our study is in 1/3 of patients with focal segmental minimal mesangial-proliferative MPGN and in glomerular sclerosis. All are in around 1/3, while the recent study found that the incidence is much higher among people with focal segmental GN, and it's reaching to about 85%. There is, as you know, bidirectional relationship between CKD and between hypertension. But when we consider the risk of hypertension in even CKD patient, it's more risky to have a cardiovascular death rather than all end-stage renal disease. And what are the risk factors which are commonly presented regarding the hypertension? There is an added risk factor in CKD, which include anemia or its treatment, because I will come across how can the treatment of anemia aggravate the blood pressure and hyperparathyroidism, and all these risk factors will further amplify the cardiovascular burden. My colleague talked about the different phenotypes of hypertension. What are the phenotypes of hypertension in CKD people? It's found that around 80% of people with hypertension and CKD are in the area of either non-dippers or even reverse dippers. And this is put the importance of the measurement of blood pressure by the ambulatory, whether home or ambulatory blood pressure, rather than office blood pressure. And it's found that in around 50% of the patients with CKD, either having a masked hypertension or even concordant uncontrolled hypertension. As you can see here from European Society Hypertension and Cardiology, they are put it in the red quarters and the risky level whenever the CKD stage above 4 and 5. So in advanced CKD, the risk is higher, and the treatment is not only pharmacological based. It depends on non-pharmacological based, pharmacological based, and even sometimes device-based management. So the importance here in advanced level of the CKD is to reduce blood pressure and put in mind the target is 140/90. There are 5 steps management in the treatment of hypertension in CKD. First, the confirmation of hypertension is based on ambulatory blood pressure measurement. Home blood pressure measurement is a bit 10 millimeter of mercury less than the ambulatory blood pressure management. The use of the RAS blocker to the maximum tolerable dose is highly advised, and we have to expect and we have to teach the patients that once we will start, there will be an expected by at least 30% elevation of the creatinine and urea within the first 3 weeks. So you can say the rule of 3, but we need to follow. And some studies, they even accept 50% rise, because let us talk in Arabic. من ابدا لازم ابلغ مريضي من ابدي له راس بلوكر، ترى انت اليوريا والكرياتينين مالتك راح تصعد. اذا كان الكرياتينين 3 اتوقع راح تصعد 4 و4.5 بالشهر الاول. لكن on the long term outcome the benefit is good. الشورت term outcome يعني ما يجينا المريض ونشوف الكرياتينين مالته صاعد unless certain conditions طبعا اللي هي الهايبركانيميا، وهم عندنا تحفظ بموضوع الهايبركانيميا. Hyperkalemia, if the readings of the serum potassium 6 milliequivalent or less, you can add potassium chelators to the RAS blocker, and don't stop RAS blocker, because the benefit outweighs the complication and the risk. And in case that the RAS blocker is not satisfactory, we can, as my colleague just talk about the use of the SGLT2 inhibitors. And this definitely when we are above stage 3 and stage 2 and so on. And we have to think of SGLT2 whether diabetic or non-diabetic CKD. In case that the step 2 and 3 is not enough and still there is a proteinuria, the addition of the mineralocorticoid receptor antagonist phyrenon is of good benefit. The addition of diuretics is very important. The loop diuretics are indicated in those patients with a GFR less than 30 milliliter, that to say stage 3B, 4, and 5. And please give higher dose of that which is practically used here in Iraq. You can use furosemide up to 250 or 500 milligram, but put in mind how much urine output is that patient having. If the patient have oliguria, not anuria, and that to say from 100 ml to 500 ml per day, then add diuretics. This is very good for the patient, and in a higher dose, increase the urine output, because by that, we are going to increase the residual kidney function. The special issue I want to talk about it is the hypertension in hemodialysis. What we call it intradialytic hypertension. هواي مرضى أثناء غسيل الكلى الدموي يصعد الضغط مالته. Definition is the elevation of the mean blood pressure more than 50 millimeter of mercury after 1 hour from the start of hemodialysis. This is بعد الساعة الأولى. هسه بعد الساعة الأولى هذا شيء مفتوح ممكن even after dialysis. By the incidence of this intradialytic hypotension is around 15%. So you can just recall it 15-15. These factors, that the activation of the sympathetic nervous system, renin-angiotensin, release of endothelin, the higher dialysate sodium, which is in the concentrate, the volume excess, and the treatment of anemia. Just I focus on it before I say anemia and its treatment. If we correct the hemoglobin by a rate more than 1 gram per month, this is faster than expected, and the patient is going to suffer from hypertension. So these factors are the drivers behind the development of intradialytic hypertension. One factor that I didn't put it here, I will talk about it, is the clearance of some antihypertensive drug by hemodialysis. And I will talk about it. This intradialytic hypertension is risky because it's linked to the development of what we call it uremic cardiomyopathy or left ventricular hypertrophy, and this definitely will increase the mortality. To just come back again, somebody say that the kidney is the captain pillars of the development of the hypertension. Is the captain. How? Because they found that when we take off bilateral nephrectomy in some hypertensive patients, they get better and normotensive state. When we transplant a normotensive kidney from a normotensive donor to a hypertensive patient, some of them are changed to normotensive state. So they found that the main and the captain pillars of the hypertension is the kidney. Just to remind you what happened and what is the primary pathogenesis that is to start with and to develop hypertension is the volume. As you know that in female, around 55% of her body fluid of her body weight is fluid, 60% in male. But at the end, 1/12 is the percent of the fluid in the intravascular compartment. So if there is any hypervolemia, which is the condition that develop whenever, as I go back again, is ask the patient with CKD, how much do you urinate per day? If there is oliguria or there is anuria, then if the patient have no limit for fluid intake, so definitely he will pass into volume overload.
رياض العفو دكتور رياض عيني عندك 1 minute.
1 minute?
Yes.
So if there is fluid high, I have higher fluid, and the sodium channels, which are the players that lead to the retention of the sodium. And this is just important thing, that the issue of the plasma refill theory. Don't be too fast, don't be too much in removing the fluid from hypertensive dialyzed patient, because once you remove it in a faster way, there will be refilling of the plasma, and this is a rebound of the problem. So another important thing, once you control the fluid in the patient with hypertension and dialysis, remember that you need at least 4 weeks for the pathogenesis to go back to the normal. And this is just related to certain factors, as I mentioned in this. The 6th point, I think I have to go on this slide. And the important now, the incidence of hypertension among peritoneal dialysis patients is much more, and around 80% of peritoneal dialysis patients have hypertension. The issue here in peritoneal dialysis, it depends mainly on osmotic gradient. I am putting glucose and the fluid inside the peritoneal cavity, and I depend on osmotic gradient. So if the patient have a faster transport character of the membrane of the peritoneum. This means that the backflow of glucose to the circulation, carrying with it the water back and volume expansion again. So that's why this is the incidence. In addition, that inflammatory condition in peritoneal dialysis is more than in hemodialysis. So here again, use of loop diuretics, ultrafiltration, RAS blocker, and just I'm talking here about transplant. In kidney transplant patients, some of them were persistently hypertension or recovered. So these are the 4 phenotypes of hypertension in kidney transplant. This is the treatment. In the first 4 weeks, I call it immediate post-transplant. And this is related to the aggressive Iraqi school. الواقع نفرح احنا من نزرع الكلى وننطي المريض فلويد وحاليا نفرح ان المريض يطلع مثلا لتر بالساعه ونظل نطي لتر. This is not the way. When I was in American, I changed my whole program. And the treatment is that what you are going to get out of the waste product from the first day of transplant in a 500 ml is the same amount of the waste that you get it off in our liter. So don't over-expand the patient with the fluid. And after 4 weeks to 12 weeks, this is the early post-transplant. Mainly here, the drugs are the factor. And the other is including the obstructive sleep apnea and the sympathetic overstimulation in kidney transplants. What take home parallels in this ambulatory blood pressure is more than depend on just pre and post dialysis or office blood pressure measurement. And the CKD, the RAS blocker, and SGLT2 firinone can help. In hemodialysis, think of volume, think of dialysate sodium, and PD, long dwell fluid rather than hypertonic dextrose. We use non-absorbable. هذا الجلوكوز اللي يرجع باك فلو ما نخليه نستخدم ايكودكستران اللي هو non-absorbable hyperosmolar fluid that can help removal of fluid. At the end, I have to tell that the kidney whispers before the heart screams from hypertension. So listen to the whispering of the kidney, and thank you very much.
Thank you, Dr. Riyal, for your precise lecture. Our next